Dialogue with a Doctor, featuring Southwest Florida's leading physicians, hosted by Dr. Gregory Leach and Jim York.
Okay, Greg.
Good evening. Welcome to Dialogue with a Doctor. We're here this evening with Dr. Robert Libbey, who's a practicing nephrologist in Naples. We're going to learn a lot about kidneys tonight. And Jim York is my co-host, as you know. Dr. Libbey, we'd like to first learn about who you are, where you came from, what your training is.
Well, thank you. I'm with Associates in Nephrology. We're primarily in Lee County. And I've been with them for 6 years. Before that, at University of Florida, Shands at Gainesville, where I trained both my internal medicine and nephrology fellowship. And before that, I was in South Carolina. We're originally from South Carolina, and some training back also in Michigan. So here in, we do cover down, we have a dialysis unit we cover here in Naples. Also one in Immokalee and 11 other units up in Lee County, as well as covering 4 hospitals and a transplant program. So pretty busy practice, but one we enjoy a lot.
How many people in your office there? How many doctors?
We're 8 doctors and 5 nurse practitioners. So it seems like a lot, but it takes a lot to cover that kind of ground.
It does seem like a lot, but that is a lot of ground. How many dialysis centers you have in Lee County, you said?
In total, there's 11 hemodialysis centers. There's a PD unit, there's a home hemodialysis unit. And that's actually going to be interesting for us, because I think as we look at the Medicare changes and healthcare changes, we're going to see a lot more people on home hemodialysis. You know, obviously we hope nobody needs to be on dialysis, but if you have to be on dialysis, the home units and the home modalities have very good outcomes and very good quality of life, particularly compared to some of the older modalities.
So I think we could start out by talking about, you know, what is a nephrologist? I know you start out in internal medicine, and then you, but tell our viewers what the practice of nephrology is and what you do.
Well, dialysis is what's most commonly associated with nephrologists. You know, nephrologists are the type of doctor that's in charge of dialysis. That's really the tip of the iceberg. If we look at statistically, less than 1% of people are on dialysis, and that's a good thing. There's probably the biggest thing I do, and the thing I get the greatest joy out of, is really arresting people's kidney disease and preventing the progression to end-stage renal disease. You know, that's probably the most benefit we can get, is if we can let people know the tools that are available and really the lifestyle choices that are available to prevent the kidneys from getting worse and prevent their health from getting worse.
So who would get kidney disease? Can you tell us, our viewers, what you mean by kidney disease?
Yeah. Really broadly, 2 groups of people. There are some congenital illnesses, and then there's the ones that are really lifestyle related, either due to diabetes or hypertension or cardiovascular disease, obstruction of the urinary system. And really, between the way those are addressed, obviously the genetic diseases, that's what you're born with, and being aware that you have those conditions and doing everything in your power to prevent those getting worse. You know, don't be a smoker, don't be overweight, make sure your blood pressure is controlled. You know, so things that we really are basic, but are, unfortunately, a lot of people kind of miss the boat on. The other aspect of it is just in terms of recognizing that you have the disease.
We're going to take a short break for just a minute, and after the break we'll come back and talk with Dr. Libbey more about nephrology and kidney disease and how to prevent it, more importantly. Thank you.
I had been a practicing orthopedic surgeon for a number of years, and I thought that I was invincible to the multitude of medical problems I saw around me every day. Was quite shocked when I received a phone call telling me that I had cancer of the prostate.
Dr. David Spellberg of Naples Urology Associates is the local specialist in treating prostate cancer with the new CyberKnife radiation treatment.
Once I got myself together was to do as much research as I could, and what I was looking for was a treatment that would give me the least risk of complications and side effects, and that's where the CyberKnife came into the picture.
Advanced CyberKnife technology, precise. It sends just the right dose of radiation to the cancerous areas, fast. Each treatment is only 1 hour, non-invasive. This outpatient procedure has almost no side effects.
The day after my treatment, I was out playing golf, and I'm looking forward now to continuing to enjoy a long and happy and comfortable life thanks to the care of my team of doctors and to the CyberKnife procedure.
Learn more about CyberKnife and Dr. Spellberg. Call today.
Welcome back to Dialogue with the Doctor. We're here with Dr. Robert Libbey, a practicing nephrologist. We're talking about kidney disease and, as I said, more importantly, prevention of kidney disease, which is close to Dr. Libbey's heart. So, Jim, you wanted to ask Dr. Libbey a question.
Dr. Libbey, how does a person realize that they might be having kidney failure or kidney disease, and just explains what CKD is?
Really, there's two sides of this. One is there are some very obvious things. If you see blood in your urine, if you see frothy, foamy urine, sort of like the foam at the edge of the beach, these are clear markers that something's going on and should be investigated. You don't want to put off that. A lot of the symptoms are very subtle. And if we relied on people to come to us with symptoms, our offices would be empty and the hospitals would be full, because unfortunately, a lot of the symptoms are nonspecific. A lot of these are a lot of the damage is done because the body has such great reserve capacity. By the time the damage is done to the point where you feel it, you may have lost a large percentage of your reserve capacity. That said, the usual symptoms that where people say, I just don't feel good, just general malaise. And as you know, there's a lot of reasons why people can feel lousy and tired. But fatigue, malaise, poor sleep, nausea, weight loss, fluid retention, just nausea, all these are sort of the nonspecific symptoms.
So if that patient goes to Dr. Leach first, or a
Right.
general practitioner, and he explains that to Dr. Leach, and Dr. Leach does blood work, I presume, or because you hear a lot of different symptoms of how you
Right.
feel. And what should the patient be looking for on their own, along with the doctor?
I think where I see people get in trouble is, maybe they don't go see Dr. Leach. Maybe they go to an herbalist or a naturalist or a chiropractor, says something. Okay, you're depressed, or you just need something to bring you up, or something of this nature. Here, take this pill; it'll make you feel better. We see a lot of injury done from, for instance, some herbal products. For instance, somebody might know they have some kidney problems. They take an herb, which is good for this, and it would be perfectly fine if they had normal kidney function. But in the setting of impaired kidney function, it can actually cause damage. I have a very dramatic example of one of our patients who ended up on dialysis and required a transplant from that reason, because of this great belief in the Chinese herb that might have helped her kidney, in fact, actually caused her kidney failure. I think the biggest thing is that you do have some blood work and a urine sample, and these are not exotic tests. These are very inexpensive, very easy to do tests, but they have to be done. You have to go and actually have a doctor who's cognizant enough to say, I don't know what's going on with you. You might be depressed. You might have just had poor sleep. You might have any of 10 other things that can make you feel lousy and tired. But let's get a little bit of blood work and see if there's anything showing up in the urine, see if there's any of the kidney function or the electrolytes.
Is kidney disease like having a heart attack? Is that a silent killer? Like having high blood pressure?
It is. And actually, if we look at the number one item to treat to prevent kidneys from getting worse, it actually is high blood pressure. You know, I have patients who will tell me, oh, I can feel when my blood pressure is high. And that scares me, because if by the time you can feel high blood pressure, you're on the verge of a stroke or you're having a TIA. I'm sure there are some people that are sensitive enough to their blood pressure, but the overwhelming majority of people do not feel their blood pressure. And they're walking around with high blood pressure, and this is causing continual damage to their kidneys. The flip side of that is that controlling the blood pressure, and particularly using certain classes of medications that we'll use very liberally, using certain classes of medicines will not only control the blood pressure, but also help prevent the progression of kidney disease. I've seen some very remarkable instances of turning around the kidney disease and stabilizing function just by getting the blood pressure under control. Kind of as a segue to that, not just the blood pressure, but if blood pressure is the number one item to control, several other things follow after that. And this would be diabetes, if you have diabetes, cholesterol, gout, if that's an issue, obesity, and so on down the line.
So these risk factors, as we call them, and I try and teach patients about them, and if a patient's coming in with blood pressure that's slightly elevated and you're trying to control that, yet the patient is saying, I don't want to take more medicine, and the longer you wait, is the length of time proportional to the injury to the kidney?
I'm not sure if it's directly proportional, but I think what I would say the flip side of that is, in a patient that you might tolerate a little bit higher blood pressure, you know, instead of saying, you know, let's get your blood pressure down to, you know, 120 over 70, all right, maybe we'll live with it being 135 over 85. But in making that decision, you'd want to make sure that, one, the patient wasn't using a lot of analgesics, you know, things like ibuprofen or Advil or Aleve, that they weren't having other comorbidities, like maybe difficulty with their prostate, or difficulty with, you know, or if they were diagnosed also with diabetes or some other condition. So I think the more risk factors you have, the more aggressive you need to be in controlling them.
So in the tests that you talked about a minute ago, urine test and blood tests, and patients are much more savvy than they used to be, and they know what some of these tests are. So what are we looking for in the urine, and what are we looking for in the blood? What blood tests specifically?
In the urine, basically, you'll do a dipstick test, and you hope that it's completely negative. Yeah, and particularly, you don't want to see any blood there, you don't want to see any protein there. If there's sugar there, that can identify, most likely they have diabetes. There are other tubular diseases which can cause sugar in the urine, and those are important to screen for. And I'll distinguish between what I might do when somebody comes to me and we do you know, an extensive array of blood tests versus just simple screening that's inexpensive to do. And the most simple is to do a urinalysis, to do a metabolic panel, and to do a CBC. The metabolic panel will tell you the kidney function and some of the basic electrolytes. The CBC will tell you, is the patient anemic? Because as it turns out, people with kidney disease will oftentimes be anemic, and sometimes they'll actually have a elevated hemoglobin secondary to the kidney, either of which is not good for you. Some of the more specific things we look at nowadays are also looking to see what somebody's uric acid is, checking their vitamin D level, checking their parathyroid hormone level, and also looking not just at the dipstick urine, but to the extent they might have you know, a more sensitive test of how much protein they have in their test, such as a microalbumin test.
So the blood test that I'm most familiar with, seeing kidney disease, the blood creatinine level,
right,
is and then the urea nitrogen, or BUN. How do those relate, or which is the most important of those two tests? Patients ask me this question.
They're both important, and it's the one tells you a lot about the other. If we look at the ratio of them, one, they have absolute values which might be high, but the trouble is, if we take three people, let's take the 80-year-old nursing home patient who hasn't been out of bed in 30 days and isn't eating much, who has a creatinine of 2, and you take yourself, if you had hopefully you don't, but if you had a creatinine of 2, and you took, let's say, someone like Arnold Schwarzenegger in his prime with a creatinine of 2. They all have the same creatinine, but the significance of it is completely different. And somebody with a high meat intake with a large muscle mass, you expect to have a high creatinine. For yourself, if you had a creatinine of 2, this might be tantamount to stage 3 kidney disease, which you would not want to have, but you would not expect any symptoms from, and would be something which would hopefully be, once you're aware of it and aware of the risk factors, could probably be stabilized and remain no worse at that for the rest of your life. Finally, the nursing home patient with that creatinine of 2, that might be somebody who's not far from dialysis. So the number, the actual value of the number has to be placed in a clinical context. The BUN, the most important thing to recognize with that is there's 4 or 5 different things that can raise the BUN, and sort of assessing the patient to see does that patient have any of those 4 or 5 things, and then looking at the ratio. Is the ratio approximately 10 to 1? That might be normal. Is it more than 20 to 1? That would suggest congestive heart failure or dehydration or perhaps steroid use. Or is it less than 10 to 1? And that would suggest the patient might have a intrinsic renal disease, some sort of injury to the tubules, which might occur with antibiotics or herbal supplements.
So you were talking earlier about causation, or at least how a patient can actually make things worse without even knowing it.
Right.
What medications, what drugs, what should we not take?
Yeah. And this is not to say you shouldn't take these, but to read the label. And every package of over-the-counter analgesics says don't take for more than 2 weeks without discussing with your doctor. And I would say, because I also have patients who have discussed it with their doctor, and say really discuss it with your doctor in detail to make sure he's looking at or she's looking at this very closely. Of all the things that are out there, these are over-the-counter. They're commonly used. I use them, reluctantly and sparingly, but because they're so widespread and people have aches and pains, they take these medicines. If you take them and intermittently, it's not a problem.
Are we talking about the anti-inflammatory medicine,
yes.
Tylenol, or are we talking about Motrin, or which medicine?
Not Tylenol. Tylenol is the great exception because it's not an anti-inflammatory, but it is over the counter. But basically everything else, the ibuprofens, the naproxen, Mobic, diclofenac, and I don't want to pick on any one of these because it's a class effect. It really is something that people need to be aware of. And not that they shouldn't take these medicines, but they should look at, say, do I really need to take this every day? Or if I've seen patients who are put on a prescription dose of a medicine 3 times a day. They say, well, my doctor put me on this. I said, that's fine, but it's probably not good for you to continue this for weeks and weeks and months. Because we see these patients and they get into trouble with it.
In your office, you have, to explain to the viewers, you have different stages of kidney failure, stage 1, stage 2. Could you explain the different stages? And maybe, I know it's probably hard to explain how long it takes to go from stage 1 to stage 2 because of the different person.
I'm going to oversimplify this a little bit and put it on kind of a percentage scale. In fact, you might have there's a measure, we call it the glomerular filtration rate. We can estimate it. You can measure it under university conditions. You can measure it under sort of ad hoc conditions. But at the end of the day, if somebody has a stage 1 or stage 2, that implies that they have normal or near normal function in terms of they're clearing the toxins. They're getting the poisons that the body generates out of the body. But they have some other problem. For instance, they may have blood in the urine, they may have protein in the urine. They have one of these genetic cystic kidney diseases where the kidney is being replaced by cyst. They may have been born with an abnormal ureter such that the urine from the bladder refluxes up into the kidney and acts like back pressure. So these are people, they have normal clearance right now, but they have some evidence that something is happening to the kidney that shouldn't be there. This next stage, the stages 3, 4, and 5 basically indicate progressively worse clearance of urine. And these can be with or without structural problems in the kidney and with or without protein and blood in the urine. And basically the largest category, 30 to 60%, so to speak, is what we see. There's probably 5% of the population. If we look at the entire population, about 5% would fall into stage 3, 4, or 5. But if we look at specifically people who are older than 65 or so, a lot of them, probably almost half, will fall into one of those stages. Does that mean that they need to see a kidney doctor? No. Does it mean they need to be careful with what they take? Absolutely. We know that people's kidney function will decrease with time. And a certain amount of that is natural aging. A certain amount of that has been accelerated by having exposure to one of many different risk factors, the diabetes, the hypertension, and such. The different stages here, though, the stage 3 is largely asymptomatic, and if your renal impairment is recognized at that point, that's actually good because, one, you're not suffering any symptoms, 2, you usually don't have any major side effects of it, and 3, it's a stage where you can look at your kind of lifestyle and say, is this, am I doing something that might be causing further harm that I could reverse? The other thing, why is this important? If I don't feel it, if I don't have any symptoms from it, and I don't have any major complications, why is it important? Well, it turns out that simply having stage 3 kidney disease is as bad for you in terms of your risk for heart attack as smoking. I mean, it makes a difference having these toxins in your body. So, and I don't want people to think, oh my gosh, I have this problem that's impairing me, but it can be a little bit of a wake-up call for people to say, you're as bad, you seem to be living a healthy lifestyle, but you're actually at risk of having a heart attack. Stage 4 is sort of this 15 to 30%. And at that point, we look at the rate at which they're declining or having stability. And if people are declining fast, despite all measures, then we start preparing for dialysis. The truth is, the majority of people in stage 4 will not end up on dialysis. But the sad truth is because a large number of those, they'll die of cardiovascular reasons. So again, it comes back to looking at lifestyle, looking at risk factors, recognize the problem to sort of optimize your health. Certainly if somebody's smoking, they should just absolutely quit that. If they're overweight, they should look at their diet because those are the huge risk factors. In addition to any beyond any medicines we can give. Stage 5, I would just simply split it into 2 areas, and that's either stage 5 not yet on dialysis or stage 5 on dialysis. And if you're at stage 5 or stage 4, either one, you want to be looking to say, either preparing for dialysis or preparing for a kidney transplant, because obviously that would be a better option than being on dialysis for this.
Why is it, if somebody were to need a kidney transplant, why is the wait time long?
Not enough donors. Not enough donors. It's, a lot of people, if you have a living donor, either related or unrelated, it could be a spouse. I think I saw somebody who recently was the best friend of the ex-girlfriend or something like this. It was, it doesn't have to be a related donor. Mm-hmm. It doesn't even have to be a close match. With the drugs that are available now, as long as there's some basic compatibilities, the living donor can have a transplant relatively soon. But we need to look at ways to expand the donor pool. And part of that's just education. A lot of people don't even realize they can be a donor. We take donors who are over age 55. We take donors with mild hypertension. And we probably wouldn't give that kidney to a 20-year-old otherwise healthy person, but it might be a good kidney for somebody that's similarly aged.
Well, thank you.
Thank
you, Dr. Libbey.
If there's anything I've learned tonight, it's prevention is more important than anything else.
Absolutely.
Because once somebody has the problem, it's bad. Well, we'd like to thank you for coming, Dr. Libbey. We learned a lot about kidneys and kidney disease, and thank you for joining us this evening with Dialogue with a Doctor, and we'll look forward to you coming and
I had been a practicing orthopedic surgeon for a number of years, and I thought that I was invincible to the multitude of medical problems I saw around me every day. Was quite shocked when I received a phone call telling me that I had prostate.
Dr. David Spellberg of Naples Urology Associates is the local specialist in treating prostate cancer with the new CyberKnife radiation treatment.
Once I got myself together was to do as much research as I could, and what I was looking for was a treatment that would give me the least risk of complications and side effects. And that's where the CyberKnife came into the picture.
Advanced CyberKnife technology, precise. It sends just the right dose of radiation to the cancerous areas, fast. Each treatment is only 1 hour, non-invasive. This outpatient procedure has almost no side effects.
The day after my treatment, I was out playing golf, and I'm looking forward now to continuing to enjoy a long and happy and comfortable life thanks to the care of my team of doctors and to the CyberKnife procedure.
Learn more about CyberKnife and Dr. Spellberg. Call today.
Good.
Welcome back to Dialogue with the Doctor, and we're finishing up this evening with Gina Aldez. She is Marketing Director for Naples Daily News, and we've invited her to the show to talk about some health publications that you're publishing. Can you tell us about them?
Sure.
About yourself.
Thank you.
First of all, Gina, thank you for being one of our sponsors this year on the Dialogue with the Doctor, and we're looking forward to working with you in the future.
Well, thank you, and thank you for having me, and we definitely enjoy working with you, and I really appreciate this opportunity. And to your point, I wanted to speak to a couple health publications that the Naples Daily News produces. The first one is our Here's to Your Health directory, and this comes out once a year. And within it, you have directories of local health professionals, and you have a photo and additional information. It's a great resource for people in the community, especially for someone like me. When I first came here, you don't have a clear idea of all of your health resources, and so this is a one-stop shop in order to do that and do a little preliminary research. Additionally, it contains articles, helpful health articles, and then as a healthcare provider, you have the opportunity to participate in this by having your listing in here, and additionally advertising. The other publication I wanted to mention, and I'll leave that right there, is a Here's to Your Health every other month publication. And this also contains some articles provided by local healthcare providers. And again, so it gives, not only the patient in the community the opportunity to learn about some healthcare issues, it also gives the healthcare the opportunity to speak to their expertise in some hot topics. And then additionally, as a healthcare provider, you have the ability to also advertise within it. And these are distributed in facilities across the area. They're actually inserted in our newspaper, so we have that circulation going. And then you can find them in your local doctor's office as well.
Our show will be, I think we'll have an ad in,
Yes.
in there telling us about, telling people about what shows are upcoming, and I
Yes.
think you mentioned we're going to have a column in there too.
Yes,
Okay.
yes, and we're looking forward to that. We're definitely looking forward to that, and it's a great way to be able to educate the community about a wide variety and range of issues and healthcare issues.
So this comes out every other month.
This one's every other month, and the directory is once a year.
All righty. Well, we
Yes.
thank you for coming.
Well, thank you for having me.
I think this is good information patients are looking for. So,
Well, thank you, and I hope so, and thank you again for your participation.
Thank you.
once again, thank you for this evening, Dialogue with the Doctor, and we hope to have you back again. Good evening.